Hey you guys, it's Heather, and today we're going to be talking about emphysema. So first off, we're going to go through, this is our table of contents. It's going to help us stay organized throughout the presentation. This is just what we were required to do for this PowerPoint, but we have the etiology, characteristics, incident rate, diagnosis, treatment, and prognosis. So diving into etiology, emphysema is defined by destructive changes in the alveolar walls and abnormal enlargement of the distal air sacs. So starting off with this, emphysema is classified as a type of COPD, and it falls under the category of COPD-A, and COPD-B is chronic bronchitis. But obviously today we're going to be focusing on emphysema. That's something very important that's not well known, and it really helps us distinguish between the two. So going into further detail, emphysema is often caused by mostly cigarette smoking, but recently with more profound usage, marijuana smoke can also cause emphysema. Air pollution in certain occupations are another big one that can cause emphysema, and these occupations include welding or cooking over foods for long periods of times. Inhaling those vapors off the metal in foods can cause inflammation to the lungs. And the final cause is due to the alpha-1 antitrypsin deficiency, and this is a predisposition that someone is born with. So when we dive over here to look at this image, up top we have first the normal alveoli, and as you can see they are separated, these little sacs are separated individually by these thin walls here, and this is what helps us trap air and expel air and helps us gather as much oxygen as we need. So when there are damage to these sacs due to these changes over here, these walls begin to break down and we end up with these large sacs here. The walls, mostly depending on the extent of damage, are pretty much destroyed all the way, and we end up with these large sacs. So to distinguish these large areas, we have the three types, and we're going to go into these more in depth, categorizing the differences with the large air sacs. But the three main types are centrosonar, panosonar, and periseptal. So the pathogenesis. This is not something that was required of the PowerPoint. However, I thought that this excerpt from the book was very helpful. I literally screenshotted this straight from our book. So if you look in the back of the book for emphysema, this pops up on the pages corresponding. But this is just a flow chart kind of explaining how pollutants or this predisposition occurs and how it affects the lungs. So we're going to start on the right side first because it's more common. When we have an inhaled substance such as tobacco smoke or air pollution, our body automatically activates the inflammatory process, and this begins phagocytosis, and we end up with a lot of macrophages and neutrophils, as you see here, and this increases the release of elastase and protease, and these, when they're released, begin the process of damaging the alveolar walls that we just saw on the previous slide. And basically this is what breaks down that tissue and collagen that make up those walls. And obviously here at the bottom, this is what we're going to see anatomically once this process begins or starts. So on the left side, we have the genetic predisposition, and basically the alpha-1 antitrypsin deficiency occurs when someone that is born with it, but it means that they have a decreased amount of antitrypsin. Excuse me if I can't pronounce that one correctly either. There's a lot of big words in this PowerPoint. However, they have a decreased amount of this, and this basically is what helps us protect our lungs. So the decreased amount obviously is going to lead to damage to the walls, and they're going to be more prone. So when we have both of these in combination, which is definitely a factor, because sometimes we can't always escape air pollution when we have a genetic predisposition, we're going to be in a lot of trouble when it comes to emphysema. So going into the three main types, so on the left side you have centrosonar, or known as centrilobular, and this affects mainly the proximal bronchioles and the upper lobules. And you see as an example here, we're kind of large up top, smaller down bottom, so obviously the top is affected. This is the most common again. The next one is the panosonar, or the panulobular, and this is the type, as you see pictured here. It affects more of the lower lobules, and this is the one that is more common with the alpha-1 antitrypsin deficiency. It is the type that comes up the most in accordance or in relation to that. And finally, the periseptal, and it's the enlarged air spaces, and it affects the peripheral lobules. And this is an example over here in cartoon form. The little arms, they look like kind of creepy arms sticking out, and a large bottom pictured here. So the next slide, it kind of really puts into perspective what these different types look like to the naked eye when we look at a real lung, as well as what it looks like on a micro CT scan. I'm not going to go in depth into this because you can pause and read for yourself. However, for the top portion, I'll kind of quickly explain. It's a control donor, and we have no issues going on here in this lung. However, as we go down south here, type B, C, and D, we have issues. So B, centrilobular, we have some pretty extensive damage here. As you see on the white arrowheads, this is what's seen to the naked eye without any kind of imaging done. They kind of look like these deep, shadowy holes, almost like you can see through the lung, so that's obviously not good. But basically in this example, we have some narrowing here, some dilation of different bronchioles and terminals. However, the lower lobules are usually not affected. In the panniolobular example here of emphysema, we have some little smaller, looks like shadow spaces almost compared to the top, but it's more of a mild destruction. However, it's still something to be concerned about. And over here we have more of the right underneath the septal region here affected. And finally, the paraseptal emphysema, and we have more peripheral damage here, and this is showing destruction near the center of the lobule is spared. However, the destruction is near the lesion near the pleural surface of the lobular septa. All right, going into characteristics. Typically when we have a patient with emphysema, some of the first signs that we're going to notice, or they're going to notice, is shortness of breath. They feel like they cannot catch their breath. Small activity or light activity really impacts them negatively. And they have an ongoing feeling of not being able to get enough air in. So this is often seen, patients might have perceived lip breathing when this occurs. They feel like that's the only way they can get adequate enough breath in. They might also have a smoker's cough or a long-term cough. This is obviously equated with smoking in general. However, when emphysema occurs, that long-term chronic cough is something that happens. Wheezing can occur. Long-term mucus production, this is something that's can be removed. We're going to talk about that later. However, ongoing fatigue is another big area that they often battle with and exhibit, and as well as this barrel chest appearance, and it's over here on the right side. We see here this character of this man is pretty normal, chest looks normal, but onto the right we have a larger expanded diaphragm, and this is because those air sacs trap air in and we can't expel them all the way, and that's something we're going to be talking about more later when we talk about testing and how to figure out if someone has emphysema. Alright, incident rate. 15 million Americans total suffer from COPD, and if you remember earlier I said COPD is two categories. We got COPD A and COPD B. Emphysema is the A type, and it approximately affected 5 million out of that total of 15 million. So the other 10 million is the type B, which is chronic bronchitis. 120,000 deaths a year result from COPD total. When we look at worldwide view, we have 251 million cases in 2016, a total of 5% of all deaths in 2015, so 3.17 million. That's a pretty astonishing number. 90% occurrences are in low and middle income countries, and this is due to occupation choices as well as the green green tendencies and adaptations that we're starting to really have an impact on our environment and economy is not necessarily available due to monetary difficulties, and exposure to tobacco smoke again is the main cause, and this equally affects men and women. And this is a new statistic because typically in the past, if you go back about 10 to 15 years, men were way more affected than women, but it's more neutral these days. So if you go over here, I have this kind of comic nice alliteration there, but it kind of talks about cigarettes and how it affects the body in several ways. So if you pause here and read through this, it pretty much in a nutshell tells you that smoking is not good and it can cause a lot of issues. Okay, going into diagnosis. So when someone has the symptoms, as I mentioned earlier, they're more than likely going to go to the doctor, and so our doctor is going to do a complete patient history as well as a physical to find findings and examination. And after we do that, we're going to do some tests. So the first test is the pulmonary functions test, and this overall is looking at our function of the lungs. So how good can we breathe? How good can we exhale? How fast are these how fast are these actions occurring? So typically when someone has this test done with emphysema, they often present with increased residual capacity, increased residual volume, increased total lung capacity. And on the decreasing side, we have a decreased ability to force expel volume. So this is how much air we can expel out in a time period, and this is measured by seconds. So typically with someone with emphysema, they can't get that air out fast. So if we go, they can't get it out. So you're going to see a longer exhale time for them. And also a decreased forced vital capacity. So the total air exhaled is less than a typical functioning person with normal lungs. The next test that's going to be done is an example of a test is chest radiograph, and this is a fancy word for chest x-ray, and we have that over here to the right. And basically, this x-ray is done just to kind of rule out any other underlying conditions or infections that the person might have, such as TB or pneumonia. And basically, when someone has emphysema, we're going to see some enlargement and dilation or swelling in the lung areas. The next test is the arterial blood gases test, and this basically is going to take a sample and measure how much oxygen and carbon dioxide is in the blood. And typically with someone with emphysema, it's more acidic and it retains more CO2. Excuse me. The final test is electrocardiogram, and this is something that people don't typically think about. However, when the lungs are under stress or are having a tough time, it's going to put strain on the heart. And so when there's strain on the heart, we have increased heart rate, or known as tachycardia. And this is one of the first signs, actually, that someone with emphysema might exhibit, or a symptom they might have due to the lungs being stressed and damaged. Okay, treatment. So how are we going to treat this person once we figure out what we got going on here? So emphysema and chronic bronchitis are treated very similarly, which is kind of good in a way. But the goals of treatment are to block the progression of the disease, return the patient back to what they were before respiratory-wise, and return the patient back to their usual ADLs or patterns of ADLs. So treatment includes, first, we're going to try to remove whatever is causing or what could be an etiologic factor, so the smoking or air pollutant that they could be inhaling on a daily basis. If it's an occupation, maybe, trying to switch jobs if all possible, or moving to a different location even for pollutants. The doctors are then going to probably prescribe a variety of different treatments depending on how well they work, but some examples are inhalers, cough suppressants, antimicrobial agents, and these help with preventing infection. Removal of secretions, bronchodilator therapy, and the last one I skipped over here is low-dose oxygen. And this is just basically important because low dosage is important because we don't want to have high doses going into the lungs, again, because those lungs cannot expel the CO2 like they're supposed to. So we have high oxygen coming in, we're going to have high CO2 coming out. So that's really important. However, we do want them to be to have good O2 levels as much as possible because that is important to overall life. Okay, prognosis. So ending up here, we're going to kind of, realize, yes, this is a chronic disease, and yes, it can't be cured. However, it can be controlled. So the 4 stages here, like most chronic diseases, we have 4 total. So stage 1 is mild. We have 80% of normal lung tissue or function here. Stage 2 is moderate, 50 to 80% lung function or tissue. Stage 3, which is severe, 30 to 50%. And stage 4 is very severe, and it's less than 30%. And this is basically the period where we're going to be like, okay, we either are going to be getting a lung transplant, or they are probably on death row because there's not much we can do. We cannot live without lungs. Okay, the final bit of information here, this is not required either, but I thought it was important to kind of keep in mind since we are all in occupational therapy field. When we have a patient with emphysema, we're really going to be focusing on how to conserve energy. So these energy conservation strategies are really important, and it also kind of carries over into this adaptations to ADLs and IADLs. And this is because we're going to be trying to alter things and make it easier so less energy is exerted and they can kind of conserve the needed energy throughout the day. We're going to be focusing on safely increasing endurance, health education, so good exercise and nutrition, which is going to be also suggested by their doctors, and mental health. So most people don't think about it, but stress and causes increased breathing rates, so how to manage that is important as well. So quickly, here are my references. And I'm going to go ahead and wrap this up, but I hope you guys learned something from this because I definitely did. I kind of went in and I didn't really know what emphysema was in comparison to COPD in general. So if you have any questions, please feel free to comment, rack my brain. I hope I can answer them as best as possible. Thank you.